We talked about that generator. The generator, if that generator is damaged, some alumina can break through, some of that molybdenum can break through. That'll interfere with the kit preparation, but more importantly, molybdenum 99 emits 740 and 780 keV photons. And so we really want to check for those injuries to make sure our generator is functioning properly. We want to see very little breakthrough through there. We always want to check our radiochemical purity, and I won't read these to you. The radionuclide purity, radiochemical purity, the chemical purity, certainly want to make sure our radiopharmaceutical is sterile as well. We do some quality control with our gamma camera. We want to make sure that we're photo peak correctly by using a small sample of a known source like technetium. We do a uniformity with a flood source. We do that with the collimator in place. That's an intrinsic, without the collimator in place is an intrinsic flood. With it in place, an extrinsic flood. We can check our resolution and our linearity using a bar phantom like this. We want to do our dose calibrator check. It's an ionization chamber we're going to use to make sure we check our doses and their appropriate amount before we give them to the patient. There's a check for constancy that we do using two very long half-life sources like cobalt-57 and cesium-137. We're going to check annually the accuracy with a calibrated source to see that it measures correctly. We're going to check our linearity by looking at a sample of technetium-99. We know the half-life of that, so we know that as we measure it repeatedly over 72 hours, it should measure appropriate values along the course. I mentioned spatial resolution. Both the collimator and the detector play a role in here. I'm not going to go into that slide anymore. I mentioned the fact that nuclear medicine images have extremely high contrast. That's why we utilize them. There's also quite a bit of noise there. We can improve that noise by getting more counts, but realize that means either a longer imaging time or a higher dose to the patient. So we really want to find that appropriate balance between the contrast we need and the noise that we will accept. There are many number of artifacts that we'll see in nuclear medicine. Damaged collimators end up, because you typically fold over the septa in the lead, end up looking like cold spots on the image. Patient motion, I think most of you have seen an example where it looks like the patient has two heads because they've changed the direction they were looking halfway through the scan. Metal worn at the patient attenuates the gamma rays escaping them. I've got an example there. Photomultiplier tube failures look like a cold spot. An off-peak image depends on where the peak was set, but if you set it down too low, you just get this very kind of scatter-looking image that's barely perceptible outline of the anatomy you're looking at. If you set it too high, you may not get much of anything in the image. And if you've got a cracked crystal, that looks very similar to the damaged collimator, but of course if you do a flood with the collimator in place and you do a flood with the collimator off, you'll quickly be able to determine which one of those two things are going on. Here's a patient with their cross right on their necklace, right, that metal attenuating there. Here's a nice cracked collimator. You see it as an artifact. You might think the patient has a metallic rod in their femur or something, but you notice when you do the flood there, it still exists, so a cracked collimator. And I'm sorry I rushed through those last few, but I was getting a little bit behind, a little more typical for me. And that concludes all the physics. Thanks, everyone, and I'll hang around a little bit if there are any questions.